Okay, thank you, Mr. Chairman. Yes, I was asked to talk on a topic which has already been covered during the meeting today. So if there is any, I wasn't able to listen to the other talk, so if there is any repetition, I'm sorry. But on the other hand, we always say in Poland that we most love the songs which we already know. So this will be something like revising and coming back. I guess you must be interested in the subject if you came here. The reason why I was asked to speak on this topic comes from two parts. Is of two parts. One, I'm just a clinician like you all are, and I see patients who needs bariatric or metabolic, as we call it now, surgery. But we've also did some studies. As you can see here, we published papers on predictors of the weight loss in patients after metabolic surgery. We showed also that a mild elevation of blood glucose. So patients who do not have yet diabetes but are morbidly obese and are operated on are at higher risk of complications. We are also, and we actually are quite proud of it, this was a small series of 3 patients, but this is the first publication in the literature on gastric bypass surgery in type 1 diabetic patients. This was a short letter in Diabetes Care, but as you always cited. Then many other small series came. Now we have large database on the type 1 diabetes patients who are obese, very difficult to treat, and who may safely undergo bariatric surgery. The problem is the same everywhere. Wherever I talk to my colleagues or you talk to other colleagues when you travel abroad, there are these patients coming to us and they are saying that they're obese, and they say, yeah, but I don't eat anything, I don't eat anything at all. So telling them, here, please try to eat less is useless, because they say, well, but I don't eat anything already, so I cannot really eat less. These patients simply do not realize how little they eat. And I guess you may draw the relationship between body weight and non-eating. At least in diabetes clinics, it goes like that. So the heavier patients are not eating anything already. So it has never been properly documented, but it's my invention, this curve, but I think this is how it really works. So that's a big mystery for our patients. Of course, we try to treat them with a diet. That's the nice analysis of all sorts of nutritional approach. And as you can see, all these have the same shape. You may even get a huge reduction, close to 18 kilograms of very low energy diet, but then later it all comes back closer to the level, the baseline level, if not crosses it up, which we call, quite unfortunately, yo-yo effect. Yo-yo is a toy, and it's not a toy thing, it's rather a drama for our patients. So then the idea of regulating appetite with pharmacology arrived, and this is one of the examples that comes from the paper from over 10 years ago. I know it's unclear, but that's my purpose. There are different compounds listed here, and the relationship between them shown between those squares and circles, showing what is the network regulating our appetite. So the idea that we will have one agent in a pill which will decrease appetite will simply not work. We design to store energy, to get energy, and not to lose it, and affecting it is very difficult. This is the list, again, a 10-year-old, showing neuropeptides which might affect, which act orexigenic or anorexigenic. So they act whether increasing or decreasing appetite. And you might even, if you look carefully, you will find dopamine here and dopamine at the bottom there. So we have the same agents, which at different concentration may stimulate or decrease appetite. So the idea of producing a pharmacological agent which would suppress appetite is really futile. This is again the list, and I show it on purpose. It's a 10-year-old list of various drug candidates done by various companies. The companies like here, drug candidates are the second left. None of them reached the market. So despite the market, we might say, so many people with obesity, and the need for such medication, this will never, I really believe it will never work We use GLP-1 receptor agonists for weight loss, but again, it doesn't bring the body weight to normal levels. It doesn't work in all the patients and so on, but it's probably quite safe. All these agents acting centrally were usually not that safe, or not as safe as you would like to thought. So this is where the surgeon comes, and the surgeons will have more and more work to do with morbidly obese patients. In the countries where metabolic surgery is the most popular, like US, less than 1% of eligible patients are operated on. So it could be 100 times more surgeries. And you see the number of total bariatric surgeries from the last 10 years, it just doubled, and it well exceeds 500,000 procedures per year. It still could be much, much more worldwide. And the other thing I want to point out is the change around 2013-2014, where we have an increasing number of sleeve gastrectomy and a decreasing number of gastric bypass. This is this red curve. So there is a change in procedures being preferred, and I will describe it in a little more detail as well. Why we got convinced to metabolic surgery? My first experience with it started in 1998, so 20 years ago. I was a very young doctor at the time, and at a large university hospital where I worked in Łódź in Poland. A surgeon who worked in this hospital left to UK for 3 years to learn more, came back from Leeds, and he said, now we will operate very big people because this is the only way they can lose weight. And we were very skeptical. We said, it's enough to tell an obese patient not to eat more, that's it, this will work. But then when we saw the results in the first 5, 10, 20 patients, we became enthusiastic because the patients were losing enormous amounts of weight. They were delighted. There were 3-4 deaths in the first year when they started to do it because there is a learning curve for the surgeons. At that time it was only open gastric bypass surgery, Rouen-Y. Some of the patients, one patient died, for example. It was a very obese lady who the next day after the surgery got off the bed, went to the sink and started to drink water because she was thirsty in an uncontrolled way, drank and drank and drank and drank so much that all the sutures in their belly just dilapidated. So she developed peritonitis, and having that thick subcutaneous tissue with peritonitis, you can't do anything. You can't take bowels out and clean them, what they do during surgery. So she died of peritonitis. Somewhat, well, to herself, she shouldn't have done it. She should be also looked at by the nurses. She wasn't so. So this was a short learning curve, and also we learned that we shouldn't operate people who are too sick. One patient had such a severe dyspnea and low saturation, and he wanted so much to be operated, and we did operate him. I mean, the surgeons, we looked after these patients before and after the surgery as diabetologists, but he died like 4 months later. He never really fully recovered after the surgery. He was simply too sick to be operated upon, but anesthesiologists said, okay, we can anesthetize him. Nowadays, it wouldn't happen. So there is a risk always at the beginning, but nowadays these procedures are extremely safe, which I'll show you in a moment. But the reason why we became so enthusiastic was this rapid weight loss and diabetes remission, because patients with diabetes are operated not just to lose weight for healthy or cosmetic reasons, but just because this is the only way we can put diabetes into remission. Surgeons call it, we cure diabetes. We don't like to say that anyone is cured, because if they gain weight, the glucose will go up, but simply they simply do not have to take any anti-diabetes medication. And it was very nicely documented recently in a paper in New England Journal of Medicine, where there was a comparison between medical treatment and metabolic surgery, with a nice reduction in body weight, HbA1c, and the columns on the right in this upper right-hand corner figure, they show that the patients who underwent gastric bypass, if you see this dark part of a third from right bar, almost half of the patients with diabetes after gastric bypass did not require any medication. So this is a very effective way of making diabetes disappear, at least disappear the need for pharmacology treatment, and we all know it very well. So today we have two procedures which are being performed. One is traditional gastric bypass, which is more complicated, requires two anastomoses, but it works well in terms of hormonal play and affecting hormonal secretion by the gut. But increasingly popular is sleeve gastrectomy on the right, where you simply cut off the longitudinal part of the stomach, making it more look like an esophagus as a pipe or part of intestines. The one thing we were again skeptical as internists about it was that you cut off a piece of the stomach and you throw it away. You cannot restore a GI tract to previous shape. While with gastric bypass, if someone decides to have everything sewed together as it was before, it can be done. But the effects of sleeve gastrectomy are very good, and it's also safe, and it's done laparoscopically. Surgeons like it, it's easy, relatively easy. So now we got used to the patients treated this way. And if we look at the 30-day reoperation rates, like with gastric banding, which is already gone, it's been used to put a band, especially adjustable band, in the upper part of the stomach, but it didn't really work. It's no longer recommended. But if you look at the bypass and sleeve gastrectomy, the mortality is 0 in sleeve gastrectomy. It is a little higher in gastric bypass, but basically mortality in these surgeries is not different from mortality in cholecystectomy. So these surgeries, these procedures have become extremely safe, and this, if the patients are selected properly, as I said, not too sick in general, with not too many complications of obesity, the procedure is really safe. So I guess I thought I would share with you some data from last month meeting in Barcelona, the AASD, where there were 3 sessions, 2 big ones, 1 smaller one, on metabolic surgery, which only shows how important the topic is. And one study which was presented, a very interesting one, it comes from Scandinavia, from Norway. They did a 1-year study, observation, randomized study comparing gastric bypass and sleeve gastrectomy. So these are the studies we need. These are the studies which are difficult to conduct, because you have to tell the patient, look, we will randomize you either in a group where we will cut out part of your stomach and throw away, or we will do a dual anastomosis in your GI tract. So in Norway they managed to do that in a randomized fashion. I don't know how they did it. We tried to do a randomized study with operating and non-operating, and it was already difficult. And what they found out, just to show you 2 results, is that with gastric bypass, patients after a year lost more weight, 29%, 23% with sleeve gastrectomy. Still, it is a lot. What we saw in our center in which where I worked, we saw when we analyzed the first 500 patients who were operated, after 6 months they lost about 1/4 of their body weight after 6 months being treated with gastric bypass. So this is more or less similar here. But gastric bypass did better. Still, sleeve gastrectomy rate is quite acceptable. But this is the most important from diabetes point of view result. Patients with gastric bypass, 75% of them went into remission with diabetes, and 1/2 after sleeve gastrectomy. So this is the trade-off. This is the situations where we can perform a safer and easier procedure, and every second patient will not need any medication for diabetes, or we can do gastric bypass surgery, and then 3/4 of the patients will not need treatment for diabetes. Still, sleeve gastrectomy effects are something interesting. So how does it happen? That's still not the question which is not answered fully. Why patients stop to be diabetes after these surgeries? The simplest answer is because they lose weight. But that's not the case. I show you where the many question marks, where they come from. So rapid weight loss is one reason, a very simple one, anyone can think about it. And of course it has something to do with the curing, in inverted commas, diabetes. Patients stop to eat as much as they used to. If they eat more, they vomit. I had a neighbor once who weighed 180 kilos, he undergo gastric bypass, and I knew he had it because he lost weight rapidly, then he gained a little. I didn't ask him too much questions because it's a neighbor, so if I got interested, he would come to me every day asking for various problems, so I don't want to be his doctor every day. We just don't like each other very much, to be honest. I can tell you what he does for a living, and then you will understand. He has a little studio where he makes porn movies, and this is how he makes money. So I'm not a saint, but it's not the way of. It's not my job. I mean, it's his problem, but still. But he has a sense of humor at the level of a porn film producer, so it's a difficult company. But still, of course, a human being. I will help you whenever he needs me. But he's not my favorite neighbor. So, but about a year after the surgery, I remember when he came up to me and said, "Oh, please do something or help me, because, I just, like yesterday, I made myself a piece of salmon. I cooked it, and it was, I put all the herbs, and it was so delicious. The guy loves eating, of course. And so he talks about it, as if he was talking about, his most beautiful actress, whatever. And it was so tasty, and I took one bite too many, and everything went to the toilet. I had to vomit. So please do something. So this is a very clear example. Once a patient tells you such a story, you will always remember this. This is an example how important it is to eat properly, not too much, small bites, and if you go one bite too far, then there is a sharp vomiting and everything goes to the toilet. So that's also the reason why they lose weight. There is a calorie restriction, but there is an enhanced postprandial satiety. I will show you this in a moment, how it happens. Taste changes, this has been well proven. So the food preferences also change. Also in terms of eating solid versus liquid fluids. We once had a patient who had again I'm going back to the selecting the proper patient. We once had a patient who had gastric bypass, everything went well, and he hasn't lost weight at all, nothing. His weight was stable. So this was kind of mysterious. He was saying he doesn't eat anything, he stopped eating and so on. And then we called his wife and a daughter and made inquiries, what is happening? And they eventually admitted that he's crazy, and he buys himself 10 bars of chocolate, melts it in a pot, takes a straw, and drinks it through the straw. I've never heard about it before. I would never have thought that anyone can do it. So after this and one other case, which gastric bypass led to psychosis, we simply, every patient who is a candidate for the surgery must have either psychiatry or psychology assessment, whether the problem is not very much in their head and the surgery will not solve anything. So with this 10 bars, and so this was our failure, is we should have checked it before, but we've never, you learn when you do things like that. So there is a change in food preference. Because we omit in gastric bypass, we omit foregut. And this is the source of plenty of hormones, so that might affect weight loss effect, incretins, and lipid malabsorption as well, and that is might be related to gut flora. This is a new area of research in metabolic surgery. We know it changes a lot in gut flora, in microbiota, either sleeve gastrectomy or gastric bypass more. Also in gastric bypass there were studies where you should do the bypass, where you should, which part of the small intestine you should adjust to this little stomach, which is remaining viable. Should it be an initial part of small intestine or the more distal part? Will this have an effect on weight loss? So, absolutely exciting area of studying. And the most recent things is about microbiota and the changes in bile salt metabolism, simply because it is also affected by gastric surgery. Nowadays, we believe it's incretins who are most important, who are most responsible for the effects, but absolutely they don't explain everything. Why it's not that simple? Why we at all think it should be obvious? People cannot eat, they lose weight, that's it. There is nothing, no need to analyze that. But what we saw, and I saw it many times, and we were really struck by that, and many centers and studies confirm it as well, that the hunger in these patients decreases the very first days after the surgery. And the weight loss, satiety goes up, and the weight loss goes down, not just because they don't eat as much as they used to. So there must be something hormonal. Okay, 3 more minutes. Yeah, I'm close. Don't worry. So that's definitely something's going on at the hormonal level here. And we have hormones candidates like GLP-1 or PYY who might be responsible for that. But now we have a longer observations as well. This is, as you can see, this is from the Asian patients, 6 years follow-up of HbA1c after the surgery. So excellent example of curing of diabetes. This is also from Asian patients. Lifestyle treatment and surgery, 5-year follow-up. Very effective control of diabetes. So no wonder we want to have more and more possibilities to treat patients like that. The latest thing which convinced us that we should use it is the evidence, and this is a publication from Diabetes Care 2 years ago, that patients with a gastric bypass had lower cardiovascular risk and lower rate of mortality. So it doesn't only cure diabetes, it saves lives. Eventually, as you know, there is this statement, which interestingly hasn't been signed by AASD, recommending the use of metabolic surgery. About 40 different associations signed it. What was controversial, and the reason why AASD has not signed it, is that it says that in patients with class 1 obesity, so BMI just over 30, if there is no effect of lifestyle and medication, consider metabolic surgery. And AASD said, well, that's too early. Surgeons say, operate everyone, operate even people with BMI 25.1, just operate them immediately. Why wait? And they have their arguments, they have evidence. While diabetologists say, well, 30 is too early to operate, we may wait. And if I may use 2 more minutes, I have more slides, but just one thing I guess we should mention. We should mention the good stuff we already listed, which is here, but there are plenty of things to remember on the downside. One thing is all the perioperative risks, but there are metabolic, self-image, anatomic and mental health consequences. And these are the things which we have to consider and talk to patients about it. There are neuropathies. We saw patients who didn't take enough vitamins after the surgery and were unable to walk, for example. There are complications like hypoglycemias, which occur even years after the surgery. So this should be mentioned to the patient as well. Weight regain, up to 20% gain is common. Patients should be warned about it. And anatomic complications may look like this. You know these pictures probably. There are plenty of skin to be removed, and if a patient has no care afterwards, that's a challenge here. And again, these are the patients with successful skin removal. And just finalizing what was at the AASD, there was a session on a very interesting session, not praising metabolic surgery, but saying where is the harm, where harm can be done. One, it's alcohol abuse. Patients after metabolic surgery drink more. There are studies showing this. One of the concepts is that alcohol is absorbed much quickly, and the effect is greater, nicer, so people want to drink more. The other thing is that there are less, eating takes the reward feeling, because you don't eat it, so you replace it with alcohol. So that's also which has to be taken into account. Suicides are much more frequent, 3 to 4 times more frequent after bariatric surgery, and there are reasons for that listed here, and some of them are depression, things like pharmacotherapy, but look at the last one, relationship destabilization. There are cases of suicides of people where the couple was morbidly obese and only one of them underwent surgery and lost weight. and was so unhappy in the relationship because started to quarrel with the one who wasn't operated and remained obese, that killed himself. So this is also the issue which we learn as we do it, that we also take it into account here. And there is a bone loss which also might happen, so vitamin D and calcium supplementation is necessary. There are plenty of studies showing all those dots on the left that osteoporosis is exacerbated, and also the fracture risk is greater. But are these drawbacks, benefits outweigh the benefits? Absolutely not. And this surgery is here to stay. We will refer more and more patients to the surgeons. The procedures will be refined. The patient selection criteria will be even more safer and more effective, or providing more effective treatment. The one thing which I also do not mention a lot today, but we should remember, is the care for after these patients after the surgery. This is the weak point everywhere, in every country. Patients are happy to be operated upon, surgeons are happy to operate, and if they don't have diabetes very quickly, they have no place to go. If there are no special post-metabolic surgery units, GPs do not know what to do with these patients, and they need follow-up constantly for at least up to 10 years after the surgery. And this should be provided somehow by our medical committee. Thank you very much, and sorry for taking the 10 minutes.
Thank you very much for this elegant presentation. But I would like to ask you about if you have a morbidly obese child or girl, do you advise bariatric surgery?
That's a very controversial issue because of safety, of course. Yes, the questions of a long-term effects of this treatment. First, we have very little evidence, but also there was a session at the AASD where the American pediatrician, can't remember her name, but you can find it at the AASD website, AASD virtual meeting, presented the data from US where they do operate adolescents at the age between 13 and 15 with good effects, saying what can we offer. The youngest person we operated in Łódź was a boy, 16 years old, who weighed 220 kilos. So when he was sitting in front of me, it was like a huge body with a little head on top. And we simply thought, if you're 16 and you're 220, what is here to lose? I mean, he will not make it until 30. Yes? This was the time before GLP-1 receptor agonists, because today we would start giving this first. But this was early beginning of the century. So we decided to operate. The parents consented. We even asked for bioethical consent because it was a 16-year-old operated by adult surgeons. It was a success. He lost over 100 of kilos, and I've seen him, I guess, 2 or 3 years ago, and he's doing great. So this will be a challenge. But there are already some evidence from US is available. You have to weigh those risks and benefits, but with such an extreme obesity, I would say whether someone is 15 or 18 doesn't really matter.
Okay. In case of sleep gastrectomy, the rate of recurrence of obesity after some time
is higher.
Then bypass? Then bypass. Yeah, we had experience here in Bariatric Hospital. We listened to Dr. Barbari. He is a professor of bariatric surgery. He operated on a child 8 years. He is a son of one of his nurse, his staff. He was, I think, more than 100 kilos, and he is 8 years. I think right now they published the paper. Right now they are starting publishing the paper as regard this issue. But actually we had recent studies about children underwent this operation. They are 13 years old. 13 years old, yes. Done by through Dr. Shazli in Asraini Hospital.
I guess it will happen like with type 1 diabetes.
Yeah.
I may just And I have, if you ask the question, I prepared the slides about type 1. Look here, this is the first paper also presented in Barcelona,
Yeah.
where they took the data from the registry in Denmark about type 1 patients. And this is like 300 patients, type 1 diabetes patients already operated. Of course, with some benefits in mortality.
They were obese,
cardiovascular disease.
type 1, and they were obese?
They were obese, type
Yes.
1 patients, but this is not a randomized study. They simply
Yeah.
took the registry from the last 15 years.
Yeah.
And they showed the data. I guess the same will happen with children. You will have a few, the other center, the other country will have a few, and this is how you will learn.
One case study,
Yeah.
and I think I will manage the post-operative nutrition. It's long-term or lifelong supplements because of the growth and the puberty.
Yeah. Fascinating thing will be to see
Yeah.
the data after 30 years.
Waiting for the publication as soon as
so
possible.
it's what will happen. But I strongly believe that you see, when we talk to obese people, as long as they are able to move around, I would say, yes, so they are able to self-help, they wash themselves, they can eat, they leave
They
their
are not
home,
dependent.
they do shopping, so they move around. Okay, we may consider various options. But the moment when they sit and they stop moving around, they just lie down or sit in the armchair, that's it. No drug will help.
Yeah.
They need surgery. And if it happens to someone who's 13, 15 years old, so what can you do?
Yes.
Yeah.
And there is no patience from the parents even just to wait.
So when I see someone who I realized he will like 170, 80, 90 kilograms, and they have difficulties in moving so much that they will not move around.
breathing, listening.
Yeah.
That's right.
It's just a surgery.
Yeah.
But in type 1 diabetes was persistent after the operation.
Yes, that was persistent. What they showed, but you take off this obesity part which deteriorates the health. So the type 1s are with gastric bypass on the red curves. So they had decreased mortality. You see 10 years follow-up from the registry. They had less heart failure. They had higher or more frequent hyperglycemia complications and hypoglycemia complications. So what gastric bypass did in type 1 increased glucose variability. So the diabetes itself was probably more difficult to control. But benefits were in mortality and macrovascular complications. So this was my summary, which I already mentioned. So again, very individual approach, but we do have a number of patients with type 1 diabetes whom we treat. Their HbA1c always comes down. Insulin requirement comes down. So overall, there are benefits. And the mean age, I remember, of the patients we operated, the first 1,000 was about 36 years of age, so really young people.
Thank you very much.
Thank you very much. Thanks.